Let me see if I can figure out the buttons here. My name is Mike Busdicker. I am the System Director of Clinical Engineering for Intermountain Healthcare. And I've been in the industry. I graduated from the Air Force Biomed School before it was the Department of Defense Biomed School. I graduated in 1983 at Wichita Falls, Texas. I know we're in Dallas. Wichita Falls about 150 miles or so north. And we used to have T-shirts that say Wichita Falls, 150 miles from Dallas, 10 miles from hell. But it's not a bad place if you've ever been there. Spent some time with the Air Force and then left the Air Force. I worked for Service Master for a period of time, as well as Aramark and Trimedics, Lexian Brothers Healthcare System in the Chicago area. And I moved just about 10 years ago out to Intermountain Healthcare in Salt Lake City, Utah. Disclaimer, they're talking points of things that I've compiled of data from Intermountain Healthcare experiences and processes and things that we've done at Intermountain. So the agenda will cover just the objectives. I'll tell you a little bit about Intermountain Healthcare, who we are, and what we've got. We'll take a quick look at early emergency preparedness, as well as emergency preparedness over the years. And then 2020, a new challenge introduced, not just healthcare, but HTM as well. And what is the current state of HTM emergency preparedness, and then emergency preparedness into the future. And one of the things that I'll tell you is I'm not afraid to stand up here and admit it, that when 2020 hit, when the COVID pandemic hit in 2020, and in March, our organization said, we are cutting off and stopping all elective surgeries, and we are reducing the business that we do at our clinics and our Instacares, and we are going to send people home to work remotely. And we started down that whole process. I'm not afraid to tell you, from my perspective, my department, the HTM or clinical engineering department, we were caught with our pants down. We were not ready for it. Not ready at all. We thought we were ready for emergency preparedness, and we thought we were ready for different disasters and things, but man, we were not ready for this. Especially 2 weeks in, we had a 5.7 earthquake, 2 weeks into the pandemic situation. So throw that in on top of everything else that was going on. So again, the objectives, to understand the early stages, we'll take a look at other disasters that have led to different things with HTM emergency preparedness. We'll look at plans and data and things that were implemented at Intermountain Healthcare, and then how HTM should prepare or should be involved with emergency preparedness going into the future. So about Intermountain Healthcare, we are an IDN based out of Salt Lake City, Utah. The organization was actually owned by the LDS Church in 1974. It was gifted to the community, the hospitals were. We currently have 24 hospitals. We just opened our newest hospital in Spanish Fork, Utah. We have broken ground on a primary children's hospital in Lehigh. We are breaking ground on a standalone ED and a women's center in Saratoga Springs. We do own our own health plan, Select Health, in the state of Utah, as well as branching out into Nevada, Idaho, and other areas as well. Our medical group was started in '94. We are seeing a shift on that medical group side. We just closed or are in the process of closing 6 of our Instacares and either converting them or building new ambulatory surgery centers. So we're seeing a shift in that direction. There are some companies startup companies that Intermountain has invested in, one of them being Castell Health. And Castell, what they do is they take the primary care model of healthcare organizations that were fee-based in the past, and how do you transition those to quality-based instead of a fee-for-care model. So Intermountain has started that business. There's another one that I haven't put up here, and that's the pharmaceutical. We have partnered with other large healthcare institutions across the country and are developing generic pharmaceuticals for some of those that are the higher cost, to try and help keep pharmaceutical costs down. We just recently, in 2020, we acquired Salzer Health. They are out of Boise, Idaho. 80 physicians, 300 caregivers, about 100,000 patients impacted throughout that area, as well as in 2019, we acquired Healthcare Partners Nevada, based out of Las Vegas, 340 providers, 1,500 caregivers. They have 55 clinics, including MyGen clinics. I don't know if you know, if you're familiar with the MyGen clinics, but they're clinics that are focused on the older generation or the older population within the communities. Of course, I don't qualify for that yet. So, you know, you got to be 35 and above. And, you know, it's, my wife is sitting in the back and she's going, yeah, no, you're not anywhere near 35. So anyways, the continuum of care, that's where our clinical engineering department falls. We've got telehealth, home care, central lab, central pharmacy. We also have life flight services. We have rotary wing and fixed wing aircraft. We actually are the only organization in the entire country that has certified lift and rescue clinical caregivers because of the mountains and stuff that we've got in there. I actually asked one of my techs one time that works on the helicopter, or you know, what the equipment in the helicopters, and I said, can you give me a ride in that? And he said, absolutely. And I said, great. He said, you see that mountain over there? Climb up it, jump off, they'll come get you. Yeah, that wasn't quite what I was looking at, but anyways, latest and greatest state-of-the-art helicopters at Intermountain. And we just acquired, it was just announced a week ago, I think, that we have acquired Classic Air Medical, which is 16 rotary wing aircraft. Hey, keep it down over there. They didn't hear me. Anyways, we acquired Classic Air Medical, 16 rotary wing, 12 fixed wing, and they serve 8 western states. So Intermountain is branching off and getting a little bit bigger and looking at doing different things within our geographic area, as well as our surrounding states and wherever else that we may be able to assist in care and treatment. Our clinical engineering support services, or HTM, broken down into 3 different operations. There are central support, where we have our system director. I also have a dedicated cybersecurity department as well. We only have 3 individuals in that. I don't have the 28 or 40 that Mayo has. I wish they did, but we have 3 that are dedicated to that: a central manager, service coordination. We do stock parts centrally at our operation because we have a courier service. I can have parts to any of my facilities within 2 hours, with the exception of St. George, although I'm hoping that's going to change. I was just on the American College of Healthcare Executives, had their Congress. It was a virtual conference, and I was on that. And the very first feature speaker that they had on there was a company called Zipline. Have you heard of Zipline? So they were live in Rwanda, and I was amazed. So they are utilizing drones. They have a launch set up. They get these drones set up and they have a compartment package area, and they put blood products in there, pharmaceuticals, just a number of different things that they put in there. They attach these things to the drones and they launch them, and they're battery operated, and it takes that drone. One of the hospitals that they were going to is 4 hours away, and they had an emergency need for blood. They put it in this thing, launched it off, and 25 minutes later, it was dropping the package at the parking lot of the hospital. 4-hour drive time. And then these drones circle and they come back, and they've got this big wire up there, and the drone comes underneath and it catches on the hook, and then it hangs, and they drop it down, and 3 guys go out and they pull it off there and disassemble it, take it back and get it ready for the next flight. And I thought, that is cool. And I found out that Novant Healthcare is in the process of working with Zipline, with their organization, and Intermountain just signed a deal with them as well to take a look at drone delivery of things. And I thought, I'm in with clinical engineering. I'm in. And man, I can send a drone out and ship parts and get it there in 15 minutes. That's a cool thing. Anyways, I'm off topic. Our CE hospital operations, 3 area directors. We have in-house CE departments, local managers and supervisors, and then our field service operations. We have regional sterilizer, central depot, system dialysis, home care. And how many of you are involved with your home care, servicing that equipment? We have, how many devices are in that, Dustin? I asked Dustin because he's a trader now. He's Nuvolo, but he used to be Intermountain. So we train them up to a certain point, and if they don't have any potential to go any higher than that, we ship them off. So devices in the home care setting. So it's a huge inventory of equipment, and we take care of that as well. And then we have regional hospital bed service. So let's talk about what we came here to talk about, and that's emergency preparedness. We're going to look at the past, the present, and the future of emergency preparedness. And I guess what I'd like to ask first, before we get into this, is how many of you have been involved with your emergency preparedness directors or managers at your local facilities? Okay. I would say from my perspective and what I've done, and a lot of my directors, what we've done is we've been involved with them because we sat on the same safety committee. But when it comes down to building emergency preparedness plans and what are we going to do if this happens, it's been extremely limited. And it's been that way for me anyways. It's been that way in the 38 years I've been in the industry. We put together an emergency preparedness piece that says, hey, if that device fails, there's a backup there. Or if that device fails, you need to put together a clinical intervention plan for that. But how involved have we been if we need to uproot and vacate? And how involved have we been if we have equipment shortages? So a little bit of history on emergency management. You can see in 1803, the first federal government involvement, and that was a fire in Portsmouth, New Hampshire. And the Red Cross, the first involvement with the Red Cross was 1809, was a flood in Johnstown, Pennsylvania. 1950, Federal Disaster Relief Program was implemented. And in 1961, Federal Emergency Preparedness Act put into place because of a 7.3 earthquake in Montana and hurricanes Donna and Carla. I didn't realize it was 1968 was the first, that's when they implemented the 911 call process. And it was instituted in Alabama and Alaska is where those were first implemented in the country. 74 Disaster Relief Act, that allows the president to do the disaster declaration. We had the first activation of the federal response plan in 2001. Remember what that was for? Trade Center. 2002, the Homeland Security Act as a result of the Trade Center disaster. Presidential directive established in 2003, establishing requirements for public health and medical preparedness. I was surprised at that it took that long for a directive on public health and medical preparedness till 2003, 18 years ago. In 2016, CMS published the Emergency Preparedness Final Rule, which covers participating providers. So anybody that's getting reimbursement on Medicare, Medicaid side, any of those things. So that was the final rule was published. And then in 2017, Joint Commission published their final emergency management standards. And here you'll see, I have a picture of early contributors to HTM emergency preparedness. There's Malcolm Ridgway here. This is Dave Francoeur. That's Stephen Grimes, Bin Sang Wang, Al Gresh, and John Craig taking notes. I'm just kidding, it's not really them. You realize that, right? I told them that I had them in my presentation, and they were wondering where. So now you can see, they go back a long way, those guys. Emergency management over the years. So what did it look like in the 1990s? What was going on in the 1990s? The first one that I've got listed up there is nationally, we had major events, including Desert Storm. Desert Storm kicked off in 1990. How did that impact HTM? I don't know about you, but I'm a veteran. I served 26 years with the Air Force. I've got veterans that are on my staff right now. What happened when Desert Storm activated? Away they went. Off to support and serve. What did we do? How did we handle it? Did we have the backups available? The other thing, what did standard HTM emergency preparedness look like for hospitals? What was the biggest thing? And I know that what everybody talked to me about, and when I sat in committee meetings, this was the big thing right here. HVA, Hazard Vulnerability Assessment. So we're going to sit down as a group and we're going to talk about, okay, we're going to do an HVA. What are the emergencies that could impact our hospital? Okay, well, let's see. We live in New York. It could be snow. We could have a lot of snow. We live in Texas. There could be, I don't know what happens in Texas. Tornadoes. Tornadoes. Armadillos, right? Armadillos. COVID. So you live in Minnesota, and in Minnesota you could have snow and then snow and then snow. And they have 2 seasons. You realize that, right? Winter and 2 weeks of bad ice fishing. I have really bad jokes. I'm sorry. You're just going to have to deal with them. Dustin's replacement, Kayla, whenever she's on a call, she always looks forward to our dad jokes. So anyways, but the hazard vulnerability assessment, so you had to look at it from a local area. What could impact us from the local area? You had to look at it from the state as well as the federal. So we had an airplane that goes down, we have a train that crashes, we have a snowstorm, we have a tornado. What are we going to do as an organization to address those things? And again, I come back to how involved was HTM in that process? And in my experience, again, was limited. They would come to us and say, okay, if we've got to pack up the hospital and move out, which equipment should we take with us? Well, we should take this equipment with us. Okay, we'll put that down on the list. Nobody came back and said, okay, if we take that equipment with us and we move it to that hospital or we move it to that building and we put it in there, does it have the power to run it? Is the water available? Do we have medical gases that are available? Those questions weren't asked, at least not in my facilities, they weren't. So we were very limited in that capacity. And I think a lot of it was because people said, that ain't gonna happen. We'll put it down on paper, but that ain't gonna happen. You can see this is an example of an HVA. I know it says Kaiser on there. I just kind of stole it off the internet. And you know, they go through and list out what some of those disasters are, what can be, you know, what are the results of that? What are the risk associated with it? What's the severity that could occur and things along those lines. So then we look at what about between 1999 and 2001? How many people remember that? Y2K, the world is coming to an end. And you know what? While it's doing that, medical equipment is going to revolt. When it switches over from 1999 to 2000, the medical equipment's going to step off the shelf and say, I am not working anymore. I'm done. You've confused me. Best Buy said, hey, remember to turn off your computer before midnight, because if you don't, it's going to explode. So Y2K, you know, I remember, I kind of look out amongst the group out here and I see some of the older generation here. I slept in the hospital that night. When the clock struck midnight, I was in the boardroom with all of the other directors in there, and we toasted with sparkling grape juice, and then I walked the floors of the hospital, and at 3 o'clock in the morning, I was back down in my office sleeping on the cot. What happened? Nothing. But we sure prepared for it, didn't we? World Trade Center occurs in 2001. The towers come down. I remember where I was at, the exact moment. The exact moment. I remember where I was at. What do you think those people, those caregivers in the hospitals in New York did when that happened? What was their first thought? Of course, their first thought may have been about the safety of the people that were involved in those towers. But once that occurred, how many casualties are there? Where are they going to go? Who are they going to bring them to? Were they ready? I would say possibly, but I bet they were not ready for the volume they received. Will we be ready? 2005, 2012, Hurricane Katrina strikes New Orleans. That's a picture of the hospital in New Orleans. Were they ready for the floodwaters to come? There was a flood in Houston not too long ago. Anybody from the Houston area? Anybody work at that hospital in Houston? You know, in Houston, when that happened, Houston said, we got to make sure we're ready. So they invested a lot of money into their hospital to make sure that if that flood occurred, it wasn't going to impact their operation. And you know what? When the flood occurred in Houston, they were ready, except they couldn't get in and out of the hospital. The hospital didn't flood, but there was no way in, no way out because of the waters that were surrounding it. So they prepared, but they weren't fully prepared. Do you know what this is? That is Mercy Hospital in Joplin, Missouri. Is it St. John's? An E5 tornado, direct hit right to the hospital. Anybody ever seen the video of the ER? Of the glass coming through in the ER? Wow. It's powerful if you see that video. Were they ready? I don't know if they were ready for that direct hit. I'll bet their hazard vulnerability assessment said tornadoes, but I wonder, I would really like to see what their plan said in case they did take that direct hit, and they did. I mean, that's the life flight helicopter that's laying there. Fort Hood, active shooter. Have we had active shooters in hospitals? Are we ready? Does our staff know what to do? At Intermountain, we do live drills. So there will be people that will penetrate. They've got guns with blanks, and they come into the building, they do live training on active shooter in our hospitals. California. Campfire, California. Has anybody seen this video? If you have not seen this video, I'm going to show it. If you have, I'm sorry, but you're going to watch it again. Well, I guess you don't have to. You could walk out, but.
Oh, it was gut-wrenching to drive through and watch buildings that I've grown up with burst into flames. So it was completely gut-wrenching.
Rescue. What is the address of the Rock Creek Powerhouse? Hey, I just got a report of a fire. Yeah, we've got another report.
So I'm driving to work, and I'm getting to the point where I can see clearly across on the way on the other side of the ridge that there was a fire.
Yeah, so I got in around 6:45. When Mark came in around 7, he came in with a piece of burnt wood in his hand. So we went outside to look, and we saw the plume of smoke.
And, you know, sure enough, you could just hold your hand out and just little black chunks of trees would land on your hand, and you could hear them pelting all the cars and everything.
And the winds were picking up. We realized that these spot fires were coming over from, hadn't even hit the top of the ridge. They were already hitting this ridge.
Already there was kind of whispers of evacuation, and they had told us not to worry the patients, but be ready to go.
And this plume of smoke that was coming over from down below was the definite indication that we needed to get our patients out.
And as we were coming around here, you know, it was just smoke zipping through the sky like fast and pieces, and you could see embers flying. And that's when this elderly woman looked up at me and she had said, "This is exactly why I don't go to the hospital."
No, I may not have direct patient interaction, but what we did in the fire is to provide a service, not necessarily to directly save the patient's life, but to assist all of the clinical staff in saving their life.
And there was no hesitation. I didn't think of anything except getting our job done and getting the patients out.
Kept going back and getting more patients. I ran back into the facility after all the patients were gone and room by room cleared and tagged all of the rooms with another one of the nurses, and then grabbed her and got out.
I turned to my staff and I said, well, we completed our job. You guys are on your own, and maybe we need to get the heck out of here. When I got in my vehicle and I came up to leave, I immediately was stuck right here.
Post-apocalyptic is the best description. It was like I was driving through a war zone, pelting my car with chunks of burning wood and sparks and embers, and it was surreal. And I honestly feared for my life. I really thought, okay, God, this is where I'm gonna die.
But I did text my daughter, who was trying to get a hold of me, and I wanted to let her know that I may not get out, and that I love her. So that really chokes me up, because there was this 5-minute period where I was really thinking to myself that this is it. We all funneled back, basically. I don't think anybody went anywhere but back here and let the fire kind of go through. I felt this was an oasis and I was safe.
I have a background in the military, and for me, it was kind of like that training just kind of kicked in, where this is just something I had to do. I was here, I was a member of this hospital. I needed to make sure that every one of these patients got out.
No, I don't think I'm a hero. At the moment, you're just doing what you need to do.
I saw people that really showed a helpfulness, I guess you could say, a humanity, that people were willing to stay as long as they possibly could and give their lives if needed for the safety of others.
Patient care is everyone's job. It's everyone's responsibility. I can look back and I can see the faces of the people that I helped to move. It's something I'm proud of, but I wouldn't call myself a hero. It's just, that was just part of my job. That's just a different aspect of my job.
What do you think? Powerful? We didn't care about the medical equipment. We didn't care about the beds. We don't care about the records. We care about the patient. It's all about the patient. I bet they had an emergency preparedness plan. I wonder how detailed that emergency preparedness plan was in case a fire came roaring up over the hill and you had minutes to evacuate your patients and get them out. Was any of that in the HTM department's emergency preparedness plan? Doubt it. Doubt it. Were they aware of the emergency preparedness plan of the hospital and what it contained and what their part in it was going to be? I don't know. I'd have to talk to them to find out, but they did what they needed to do. And I guess what I want to emphasize on that is it's all about the patient. The other thing that I wondered about that as well is in that HTM department, and I'll cover this in a little bit as well, is do you have the contact information for your caregivers, for their home contact information, their emergency contact information? He called his daughter and said, I love you and I'm not sure I'm coming out of this. How many of the other loved ones of those other caregivers were wondering about their family members and nobody reached out? Or maybe they did, I don't know. But I know I have that information now. I didn't in the past, but I do now. And on that, I just recently had a caregiver that was in on a Sunday doing a PM on a Medivator. And he was in the hospital doing the PM, and he got up, he walked out into the hallway, he wasn't feeling well, he crashed against the wall of a pharmacy, went down, staff came out, they administered to him. Unfortunately, they were not able to revive him. He passed away of a heart attack in the hospital after doing his PM. And when they got a hold of the director of the department, he started looking, he didn't have the contact information for this guy's wife. And it took him a period of time going through HR to get that data and information. To me, it's part of emergency preparedness, part of the plan. A new challenge. Like I said, the past year has been extremely interesting. In November of 2019, the first COVID-19 coronavirus case is reported in China. Well, now whether that's the first case or not, I don't know, is the first case that was reported. And then in January of 2020, the first case is reported in the United States. By July 7th of 2020, there were over 3 million cases in the United States, and that includes over 40,000 hospitalized. That's by July 7th. January, the first case is reported. By July, 40,000 hospitalizations. It required some drastic changes. Remote work for non-essential workers. Safety considerations. Facility restrictions went into place for visitors and suppliers. We had local, state, and federal command centers. We had to implement things like equipment and staff tracking and reporting. How are we going to report that information, and how are we going to continue operations? Again, when COVID hit and the mandates started to come down, we had an emergency preparedness plan, but it wasn't robust enough for this. You know, we had talked about before, if we have to vacate the facility, where do we go to work from? We had that outlined, but when we said we're going to work remotely from home for non-essential workers, all of a sudden my service coordinators, some of my managers and directors that are at the front line at the central office, our parts and inventory person, our data analyst, all of a sudden now they're at home. They're not in the shop. So how do I keep getting my data? How do we continue operations? How do we set them up so that they've got functionality at home? That wasn't in the emergency management plan. We didn't identify that. Local, state, and federal command center, or local, state, and federal command centers, are we part of that? Are we not part of it? We weren't in that emergency preparedness planning session. We knew that safety management was in there, emergency management was in there, hospital leadership was in there. They didn't have HTM representation. And what was the first thing they wanted to know? How many ventilators do we have? Well, who's got that info? Wasn't in the plan. So, current state. Some of the things that we've done at Intermountain Healthcare. So we took a look at our strategies and outcomes. We knew that there was facility level incident command, system logistics command, and a state command center, and we made sure that we were part of that process. We didn't actually sit on that state command center. We didn't have a seat at the table on that one, but our information was being funneled there through the person from our system that did sit on it. Every single morning, they got that data to take that to that command center. The logistics command center, we were an integral part of that because we were looking at equipment, supplies, consumables, equipment usage. We started looking at daily reports from our staff. Every single day, I got reports from my staff saying, what is your caregiver status and what does our shift coverage look like? We started looking at ventilator reports, usage stats, locally, system, and state level. So now, all of a sudden, instead of competitor A that's down the road, who we don't want anything to do with, Now we're communicating because they need to know how many vents I have. I need to know how many they have. And if I've got one that goes down and I don't have the part for it, maybe they do. So now all of a sudden, we're not competitors anymore. Now we're healthcare providers. We didn't establish those relationships in the past. We do now, but we didn't have them in the past. Do you have those relationships with your competitor hospitals? Surge preparation. Numbers are doing this, numbers are doing this, numbers are doing this. And the state of Utah said, wow, we are doing great. We're not going to see the surge. And then Intermountain Healthcare came out and said, you're way too far ahead of the game here. We don't anticipate the surge happening until September. And the state of Utah said, well, you're crazy. And guess what happened in September? The numbers went through the roof. And all of a sudden, our ICU capacity, you know, we went from 50% to 90%, 95% occupancy in our ICUs. Now what do? We don't have enough beds. We don't have enough ventilators. We don't have enough feeding pumps. What are we going to do? So we had to start standing up additional units. Wasn't in the HTM emergency preparedness plan to stand up additional ICUs. That wasn't in there. So we started looking at, as well as from an HTM perspective, we started looking at daily staff assessments. What do their workloads look like? What is their family status? Because their mental well-being is just as important as their physical well-being. So what is their family status? We started looking at data and information on evaluation of PM cycles and equipment in use. Do we need to use the CMS? Do we need to use the 1135 waiver that allows us to extend out PMs so we don't have to complete them in those months? Can we use that waiver? Do we need to use that waiver? We started looking at what are our shortages across not just our own system, but the entire state to support the communities that we have in the state. What are the shortages? Where can we help out with that? What is our system level resource sharing? Can we move resources within the system to ensure we've got coverage? Can we pull from our other competitors as well as offer that assistance in order to make sure, again, it's all about the patient and having that established. We started looking at surge preparation. How many of you heard multi-patient use for one ventilator? You can put 4 patients on one vent. And the doctors went, that's stupid. And we said, we can do it. And they said, show us. So we had to rig it up and figure out and how to do it. So we 3D printed some of the ventilator tubing parts so that we could expand that out and do it and show them that we could do it. We had to repurpose some of the patient care areas. Some of our pediatric units, because it didn't hit pediatrics as hard, we took those pediatric units and converted them to adult units. So 2020, a whole new emergency preparedness. Really, it was uncharted territory. We had to support 100% temperature checks for everybody. You walk to the hospital door, you get your temperature checked before you walk in. Well, guess what? We didn't have enough thermometers. You think you would, but we bought 400 new ones. Drive-through testing sites. We had to support those from an HTM perspective because we support PAPRs and some of the other PPE. So we had to support that. Wasn't in our emergency management plan, as well as we had to take a look at our staff and say, how many of them have been fit tested for N95s? How many of them have been trained on the use of PAPRs? Because if that ventilator breaks in that patient room, that patient is COVID positive, who's gonna fix it? Who's gonna go in and look at it? And if it's our staff, they have put PAPRs on. And have they been trained on the use? Parts availability, bed shortages, space limitations. I mean, the list goes on and on and on when you start thinking about this. So updates to our business continuity plan. We really did put together a fairly robust, we took our business continuity plan that we had before, blew it all up and started over. Now we salvaged parts of it, but we really took a look at it and said, what is the purpose, scope, and objectives? What is the risk assessment? What is the risk assessment from past experiences, present experiences, and things that we could see in the future? What is our organizational structure and chain of command? Not just within our local facilities, but the system as a whole, as well as the state. What does that look like? What is our greatest threat potential for our department? Is it transportation to and from the facilities? Is it communication? Is the greatest threat potential that 75% of our staff are going to come down COVID positive, and now all of a sudden we have 25% of the staff trying to do 125% of the work? Is that the greatest risk? What is our greatest threat potential? And based on that, what is our response? Are we going to be able to continue operations as normal? And if not, how are we going to adjust? What are we going to adjust? Are we going to do the resource sharing? We even had in our business continuity plan that we reached out to a couple of independent service organizations and said, if we have a staff shortage and all of our staff gets COVID, can you bring people in to support us? And I know a lot of people from an in-house perspective say, I'm standing back from that because the last thing I want is to be outsourced. We're not talking about outsourcing, we're talking about working together for patient care and treatment. And then the recovery phase. What do you do in the recovery phase? How do you do the software reloads? How do you do equipment resets? What's the date, time, action? What's the potential expense as you look at those business continuity plans and emergency preparedness? Some of the forms that we had. So we have forms that are attached to our business continuity plans, and one of those forms is our critical suppliers. Who are they? Who are our critical suppliers on the HTM side? Who are our main mission critical service suppliers, whether it be for our CT, MR, whatever equipment it is? Who are those critical suppliers? What is their contact info and what are their names? As well as we wanted to take a look at it and say, what are your business continuity plans? And I don't want your plan from a national perspective. I want your business continuity plan that says, if you run into a problem, this is how you're going to support me. Not everybody across the nation, but how are you going to support me? I want your business continuity plan. I want a copy of it. Home locations. Again, I talked about the home locations of the critical staff. Where do they live? What are the phone numbers? Who is their emergency point of contact? Damage assessment and documentation. Looking at what is the location? Is it recoverable? What's the condition of the equipment? Expense. We may have caregivers that have expenses, and how are they going to get reimbursed for that? What if they're sick and they get COVID? What is their process for leave of absence and ensure that they're continue to be paid yet? How does that go into effect? And then again, our post-emergency tasks. So inventories, validating those inventories, debriefing the staff, looking at insurance and how do we get reimbursed at and those areas. And then the self-assessment of HTM emergency readiness. Again, I really don't think as HTM, as an industry, we have been as intertwined with emergency preparedness directors within our facilities that we should be. We are just as important as those clinical caregivers that are providing the patient care and treatment, because they can't do it if that equipment's not available. We're just as important, and we should be in that emergency management planning session and part of it, a very integral part of it. We need to take a look at our healthcare organization, look at the overview and profile. What's our trauma designation? If I walked up to your clinical caregivers in your department and said, what's the trauma designation of your facility? Would they be able to tell me? If I said, how many negative pressure rooms do you have? Would they be able to tell me? If I said, how many ICU beds do you have? Would they be able to tell me? Do they have that information? Do they have an overview of the hospital? Do they know what the hospital is about? Have we looked at, from logistics and facilities, have we looked at emergency power, water supply, medical gases? And I'm talking about relocation to another facility. If this is our designated alternate facility, are those things available? Because if they're not, we're going to have a tough time providing patient care and treatment to critical patients anyways. Preparedness and training, respiratory protection, fit testing, training. How many of our HTM staff members or our caregivers have had that training? Incident command systems and communication. Make sure that you've got an assigned spot in that incident command. Has to be critical that HTM is represented there. Have we done any exercises? And if the hospital does exercises in emergency preparedness, is HTM involved? As you can see in the California fire, those HTM caregivers were involved, but not on the HTM side. Manpower, patient care and safety, movement of patients. So if the facility does an exercise and HTM doesn't have a role in it, they can still have a role in it and be an assistance to the organization. Local, state, federal assistance agreements. Do you have memorandums of understanding? What are your rental companies or suppliers? The collaboration with other organizations. Again, yeah, we might be competitors, but in a state of disaster and emergency, the important thing is our patients and the communities that we serve. Organizational service offerings. You know, what do we have from a pharmacy, laboratory, logistics and supplies, communication, information management, identify the critical systems. If communication goes down, what do we do as an HTM department? Do we have any capabilities? I know I've got some people that are ham radio operators. And do I leverage that in my emergency management plan? No, not right now, but I could and I should. And with that,